and then take measures on a national scale to solve them.
Doctor, do you think that would work?
Well, we have really substantial evidence to show that we can dramatically drop and really reduce these preventable errors right down to zero. And the National Quality Forum Safe Practices released last week, and Dennis was part of releasing them at the National Press Club, have shown that you could actually drop many, many of these to zero. We don't have bad people, we have bad systems.
So how do you go about doing that? I mean, how do you drop them to zero?
Well, basically, it's amazing. There are so many simple things that we do every day in healthcare that could be more standardized with basic safe practices and predictable outcomes. And this has been established in many studies. Leading experts agree that many of these areas can be dropped almost to zero.
It's really a combination of leadership, safe practices, and technologies.
You've talked in the past about a conspiracy of silence among medical providers when errors happen. That they kind of circle the wagons. I mean, is that, you think, because they're afraid of being sued?
Well, I think it's a number of issues, but yeah, I think that's what it gets down to begin with. We were met at the door with this incident occurred with our twins, who, first by the doctors and then immediately by risk management, which was really to control liability. And there is, as I said, a conspiracy of silence that happens because of that fear of liability. Caregivers, which I think is wrongly so, are criminalized for making mistakes that are basically predictable human error.
And Doctor, I mean, it sounds so reasonable. Okay, you obviously try to eliminate as many mistakes as possible, but there is resistance. I mean, to your efforts.
Well, there is, but and that's why we put together the documentary, and we're so grateful for Dennis to help us gain the attention. We have a number of winners and role models in this documentary that have shown they can face. we talk about fear being the Goliath, and that they have to activate their inner David, the leaders of hospitals, and this. Typical hospitals at the front line are pretty resistant, and the status quo is really the enemy. It's not bad people, it's bad system.
And Dennis, beyond obviously the big picture of what you're trying to do, what's your advice to folks who find themselves in the hospital or dealing with a situation where they're not sure what's going on? I mean, what's your best method for surviving a hospital stay?
Well, number one, never stay in a hospital alone. Always have a friend or a loved one there with you in the hospital. And second, ask questions. Ask nagging questions, really, if you don't understand something, and have people explain what they're doing, why they're doing it.
A couple other things. When patients leave the hospital, they should make sure to get their medical records and be able to be part of the team to get those records to the next caregiver. Ask everybody to wash their hands who they're working with, and when you get home, make sure that you have the list of your medicines and that you're taking the right medicines and reconciling it. Those are simple things that everybody can do.
What did you guys think of that video?
I hadn't seen it.
You had already seen it? The same one or like a longer one? Same one? I saw the same video like an hour long. There's an hour long one, but it talks about all different scenarios and things that have occurred and why and how to fix it. And what did you think of it, Juan?
Well, I know there's mistakes in the hospital, and I know that it happens. Either you can cut down everything down to it, but there's still going to be human error involved. It's an error. It's not at fault.
Mm-hmm.
It's not. And the outcome can be worse. It is bad, but it's an error. And I don't think they should be prosecuting the nurses to the point where they're at. Like take them to the legal things and all this other stuff and do that. And it's just an error. And they should be done something about it, maybe remedial education and all that stuff. But to take them to that point, I didn't intentionally do this on purpose.
Right. Like I heard the word in there, it's a system, right?
It's the system.
It's not a nurse, it's not a person. It's an error.
It's an
Nobody ever intends to hurt anybody.
We never
But
Especially us.
the system, I mean, even with the perfect system,
Like the nurse,
There's too many parts,
There's too many parts.
and it happens, and it shouldn't be criminalized for it, right? We should be able to feel like we can say, hey, I made a mistake, or
The
hey, I
fear
don't
of being
understand.
criminalized, being blamed and being taken to, is the part that keeps us from saying, being honest.
Mm-hmm, because
And
you
that's
get
the-
scared.
You get scared.
like the nurse from Vanderbilt yesterday that was charged with homicide that gave Norcuron instead of Versed because she just looked up VE in the system in the Pyxis and grabbed out Vernoc. I can never say it, but so she gave a paralytic instead of Versed for an MRI patient. And she was like the float nurse or the resource nurse or something, but the whole system is why the patient died. Is
Mhm.
because one, she should have never looked up the medicine like that. The Pyxis should have never given it to her. It should have been a med that if you overrode something, then it needed a double signature. You shouldn't be given Versed without monitoring the patient anyway. The patient wasn't monitored. They were in an MRI for 30 minutes. And, I mean, there's so many places that went wrong, but yet she just got charged with
Exactly.
homicide.
Right, so that she shouldn't have been criminalized, or she
have
shouldn't
been-
be
I
criminalized.
believe that
That should be a process
if
improvement.
something happens or something, something happens but the patient didn't receive harm, it should be handled in-house as a community, as peer review and something like that. And we've done other stuff. I know the nursing board allows you to make 5 mistakes per year to make.
Oh, really?
Yeah, they give
I
you
didn't know
5,
that.
yeah,
Either.
they give you 5
5.
mistakes.
Does it
And,
depend on,
mistake?
does it
it can
depend
be
on the
little
level?
errors and little things. They say that you're allowed 5 mistakes, but if they are reported to the nursing board, they're gonna do something about it. Okay? But if they say it was necessary, hey, you gave a multivitamin to a patient, you probably helped him out rather than did harm to him. Don't do it again, learn this and take this educational class.
Yeah,
Don't say, hey, I'm gonna throw the book at you.
right, and I think they are trying to do that, like they're changing
Yeah.
as a result of things like this, like people that come in and they realize that this is a process.
Yeah.
And that's one of the reasons why they have the national patient safety goals, is to make everybody more aware. And that's why they try to perfect the processes, to make them better, to hopefully prevent those mistakes.
Prevent and
I think
educate.
besides the process, I think also, I haven't been on the floor myself, but from what I've seen, nurses are real busy. So I think they should do also like in California, the ratios here as
The
well.
ratios.
Yeah, so that way you have more time, go over your 5 rides, 6 rides, whatever it is, and you're prone to make those mistakes
Unfortunately,
when you
the
take your time.
on that perspective, the valley is built on volume.
Yes,
And that's what
it's
we
hard
do.
sometimes to get
It's
the
hard
staff,
to do.
not because you don't want it, but
Mhm.
because there's just nobody left.
Yeah, it's volume.
And so that,
volume,
it's a
volume.
process, it's a process,
More,
system.
And this is the way this town was built. McAllen and all that. You go upstate to San Antonio, Corpus, even like other states, and they don't do volume. They just do specialties. And they do almost do specialties.
And acuity, they base a lot of staffing on acuity, but they can't because they have the volume of staff.
Yeah. Volume.
Okay. One of the goals is identify safety risks inherent in population. Have you guys heard that one before? So that means like there's just certain safety risks that occur just by being within a population. For example, individuals at risk for suicide. So hospitals need to find a way to identify patients that are at risk for suicide and then help them. So one way that we do that here at Nat Medical Center is we assess every single patient that comes in the door for suicide risk. And there's certain questions that they ask them, and if they become positive, if they ask like, how likely is it that you will commit suicide someday? And if they say very likely, for example, then there's like a policy that we follow. We put them on a 1-to-1, we remove their telephone cord from their room, etc., to try to protect them. The other flip side of that is they're not always going to just come out and tell you that they're suicidal, but there may be subtle things that they're saying or doing that makes you think that they are. So it's always a good idea to report. We have social workers, case managers, even sometimes like nursing students that are on the floor, they spend more time with the patients, they'll get something out of them that doesn't seem right. It's always a good idea just to let somebody know, report it, and investigate further rather than not, just to make sure that our patients are safe. Have you guys heard of this one? Susan's heard of it? How about you, Rita? Do you know what that means?
No.
No? So there is actually harm from incorrect use of alarms, nationally, locally, and globally. And it's because there's so many alarms going off, especially like an intensive care unit, that it starts to get like to where we drown it out and we don't hear it and we get tired and we don't answer them. A study was done that says 80 to 90% of alarms that go off are usually nuisance alarms, meaning they're going off and they shouldn't be, or they're going off for the wrong reason, and then they get ignored eventually. And then the ones that are really, really important accidentally get ignored and then a patient gets harmed. Like for example, a telemetry pack showing flatline and people think, oh, that was showing flatline, or that was, they don't go running to the bed right away because they're tired of going over and over. And in this case, the patient actually wasn't, they didn't take it off, they're actually flatline, you know, for example. I'm sure you guys have heard of those examples. And then the opposite of that is that you're running around canceling alarms all day and you're freaking out because all you hear is alarms, alarms, alarms. So Joint Commission, and of course we probably know this ourselves, advocates individualizing alarms. And I know Juan can tell us what that means, right? To individualize an alarm to a patient?
Individualizing the alarm for the patient.
Or I think you tell us what it means.
I think I can.
Okay.
I think I know what it is, but individualizing, each patient will have their own specific alarm. I think that's what it is. Individualizing it?
Or I guess what I'm saying is, well, maybe Susan knows what I'm saying.
If a patient has a normal heart rate that's bradycardic, then set the alarm lower than you would on another patient.
Oh.
Or like
Yeah.
you have a COPDer who lives with an O2 sat of 80 something, don't set it for 90 because they're not gonna be 90 and the doctors probably don't even want them at 90.
Right.
Because they found that if you set the pulse ox alarm at 88 versus 90, it reduces so many unnecessary pulse ox alarms.
Exactly.
And the patients are fine at
Exactly.
88.
So if you have like
Just
an
that
athlete,
just that two.
An athlete.
and their heart rate's always 50, and they
Yeah.
tell you, my heart rate's been 50 for 3 years, and the thing keeps going off because of the patient's heart rate, like every time it hits 55, it goes off. Set that thing to 49, right? So it doesn't go off as often because you know the patient's fine. If you're ever in doubt though, call and speak to the doctor and just make sure, right? But usually we know, and the patient knows themselves better than us, so they're gonna tell us, my heart rate's always that way, it always does that, right? So that's what it means by individualized. And this brings us to another question. Let me have Rita read that and answer that one.
I don't wear my glasses, but I can.
Oh,
That's fine. Which one of the following is the most important factor to prevent a surgical site infection? Proper hand washing.
yay.
Yay!
Always.
Always hand washing, right?
Always.
Okay, that was too easy. And so reducing risk healthcare associated infections by washing our hands is the main way, right? And then Susan and I were talking a little bit about catheters. We want to not use catheters unless we absolutely have to. And you want to use your proper technique with central lines and using antibiotics appropriately, right? Can help reduce multi-drug resistant infections. So just little things that we can do to prevent healthcare associated infections. I'm only touching on some of these slides because I'm going to go deeper into identifying patients and SBAR. There's another question. I'll let Susan do that one.
Medical, select the accurate response regarding medical errors. I put all of the above.
All of the
Medical
above.
errors are the third leading cause of death in heart disease. After heart disease and cancer, more than 250,000 people die each year from medical errors, and they cause 9.5% of deaths each year.
Wow, right? That's kind of like that video that we watched. It just kind of opened our eyes to make sure that if we're ever unsure of what we're doing or have that, I don't know, I call it like a sixth sense or something, you feel like something's not quite right, stop what you're doing, take a deep breath, and reanalyze, reassess the situation.
I had a question
Uh-huh.
on since we're talking about medical errors, I know a lot of nurses have like a personal insurance. Is that something, like, I mean, so like, is that everyone carries it? How are we protected, like from a lawsuit or?
Now, the hospital is supposed to protect us, however, a lot of people will get their own insurance too because they're not sure to what degree, when it really happens. I don't know, what's your opinion? Right now, I do have liability insurance.
I've had liability insurance since day one, and I will continue to have. It's $109 a year, and it used to be $89. So it's only gone up $20 in 26 years.
What provider is using?
Shoot, I don't remember. NSO.
Oh, like there's several different.
There's several, yeah, I need to look up and see what one I'm in.
Because the hospital, yeah, they cover you, but they ultimately will look out for themselves before they look out